Good evening, everyone, and thank you to SAGES for having me to present our group study on a systematic review of looking at choledocholithiasis management post Roux-en-Y gastric bypass. We have no disclosures to declare. So we are in the midst of an obesity epidemic, and the Roux-en-Y gastric bypass has now become the second most commonly performed bariatric procedure. The massive weight loss after bariatric surgery is a known risk factor for choledocholithiasis development, and about 0.2% of patients with post-Roux-en-Y gastric bypass can develop choledocholithiasis. Due to the difficulty or the post-surgical anatomy, there's difficulty in accessing the ampulla through conventional ERCP methods. So many procedures have been described in the literature, and we will go over and review some of the procedures we have mentioned. So first, the most commonly performed procedure to access the CBD would be the laparoscopic transgastric ERCP. This is done with laparoscopic access into the abdomen, a creation of gastrostomy into the gastric remnant, and subsequent ERCP through the biliopancreatic limb antegrade. The advantage of this would be to allow for a concurrent cholecystectomy at the index procedure during this. Balloon-assisted enteroscopy is an umbrella term that includes a deep cannulation of the gastrointestinal tract and the small bowel, usually done with a single or a double balloon. This allows cannulation down the roux limb and retrograde through the biliopancreatic limb to access the ampulla for ERCP. The endoscopic ultrasound-directed transgastric ERCP, or EDGE, is the creation of a gastrogastric fistula through endoscopy and endoscopic ultrasound to place a self-expanding metal stent, and then this will allow ERCP to be performed in a conventional way. The EUS-guided intrahepatic puncture with antegrade clearance is similar to the EDGE, but the fistula is created between the stomach, the gastric pouch, and the dilated left hepatic duct, and allows for cannulation and antegrade clearance of the stone. This is usually reserved for smaller stones. And if all else fails, we can always perform the common bile duct exploration in the open or laparoscopic fashion. So to answer our question of which of these procedures is beneficial, we performed a systematic review according to PRISMA guidelines. As none of the studies that we were included had direct comparisons between the studies, we did a pooled proportion analysis in our pooled studies. Our inclusion criteria included any studies that reported on CBD stone clearance in adult patients with Roux-en-Y gastric bypass. And due to the large volume of small case reports and case series, we only included patients or studies with greater or more than 5 patients. Our primary outcome was a successful stone extraction, and secondary outcomes included procedure duration, length of stay, and adverse events. So we had 2,600 studies after duplicates were removed from over 5,000 hits, and these were reviewed by one author, revealing 191 full-text studies that were assessed by 2 authors, and 40 primary studies were included in our systematic review. Out of these 40 studies, 31 were retrospective cohort studies. There are 7 case series and 2 prospective cohort studies. They were published between 2005 and 2019, and this accounted for a total of 566 patients. Looking at our primary outcome, we noticed that the laparoscopic assisted ERCP, endoscopic ultrasound directed ERCP, and laparoscopic common bile duct exploration all had excellent results of over 90% of stone clearance, whereas balloon assisted enteroscopy and the intrahepatic antegrade clearance had lower stone clearance. However, as mentioned before, is because there were none were randomized or comparisons between any studies, we can't directly compare between these. And in terms of our secondary outcomes, the laparoscopic ERCP was the longest with 133 minutes. However, a quarter of these reported concurrent cholecystectomies, which may added to the time. And the endoscopic ultrasound ERCP was the shortest in duration. In terms of adverse effects, the EUS guided one had the highest amount of complication, mostly related to the stent migration and stent displacement, and whereas balloon-assisted enteroscopy had the lowest number of adverse outcomes. The surgical option, most of their adverse events were results of skin infections and post-ERCP pancreatitis. Our risk of assessment bias showed mostly low risk, and most of the unclear risk is due to the abstracts not adequately describing their methodology. And our results show that there's high success rate of stone management in choledocholithiasis by accessing the gastric remnant, whether it be surgical, laparoscopically, or with EUS guidance to create a fistula. And the lowest complication rates, although not as successful, was the balloon-assisted enteroscopy. Overall, this is a low quality of evidence in terms of the primary studies alone, and there's variability in procedures and availability of the different procedures between institutions. So we conclude that laparoscopic ERCP is a reasonable first-line consideration due to safety and success, especially if patients would require a concurrent cholecystectomy. And in non-operative candidates in higher risk individuals, endoscopic access of the gastric remnant is also possible. Thank you, and I'll be happy to take any questions.